Okay, everyone, thank you for joining us. This is Seth Sinclair here, President and CEO of Plan 4 Healthcare, I should say COO. We had a great response for this particular session today. We had over 50 people registering based on the last time I looked. And just like last time, based on what I've seen, we've got folks from all across the country, a lot of folks from inside VA, but some outside, and participants at many levels in the organization, from the executive to the management level, which is great. This is our second webinar in the series. We're going to keep going from here, but for now, this is the second one that we've gotten going with. All these topics we picked are those that we've heard feedback from our observation, working out in the field, doing planning work, that these are areas that people would like to learn more about. And some of those sites are very large sites, some of the biggest in the VA system in urban settings, and some are very small level 3 facilities in rural settings. But regardless of that, we hear a lot of the same themes from site to site, and we just would like to be able to share some knowledge around these areas. Like last time, this is going to be primarily just knowledge sharing. This is not a sales pitch. Later, you might hear us refer to some of our best practices, but that was not the focus of why we wanted to do this. This will be mostly a discussion style session between myself and Lynn Ryan, who I'm going to introduce here momentarily, who's our featured panelist. You can, in the audience, ask questions using the GoToWebinar tool. If we can't respond immediately, we will monitor those and try to answer them as quickly as possible. And there may be points where we can't open up the microphone as well, so hang tight for that. Know that we will stop promptly at 1 o'clock Eastern. A recording will be available. We'll send that back out like we did last time for everybody who registered. And then just know this time we're going to do at least one poll as part of this session. We're going to test that out, and so hang tight for that. All right, let's move forward here. Okay, what were the specific goals for this webinar? Well, we picked this topic because, again, medical centers getting their budgets from our observation, a lot of folks out in the field don't understand it, and we understand that the confusion around it, because quite honestly it is confusing, and at least from my view, there isn't a lot of very readily available clear information that covers the process from end to end. And yet at the same time, we do truly believe it is important for leaders and managers to have a good grip on this process, because it can help them with their local planning, and also to understand the financial position of the facility and then how they fit into the bigger picture of the overall organization. So our hope today is to cover that overall process, how the budgets are developed, some key variables in there specifically that affect the allocations down to the medical center level. And then toward the end, we want to talk about things that at that local level, what are some of the considerations that facility level leaders and managers can think about when it comes to, basically maximizing their revenue, but also maximizing the entirety of their budget. All right, so let's keep moving forward here. And just again, to make proper introductions, again, this is Seth Sinclair with Plan 4 Healthcare. I've had the privilege of working with many VA hospitals, especially with regard to strategic and operational planning. And I do a little bit of everything between on-site project management and serving as a consultant and working on these best practices that we use when we work on site. And our featured panelist today, I'm pleased to introduce Lynn Ryan. I've had the honor of knowing and working with Lynn for several years, and I can tell you guys that I've come across no one who could do a better job of helping us with this topic today. Lynn, would you take a moment and introduce yourself?
Yes, Seth, thanks a lot. And I'm Lynn Ryan. I'm a former VA employee. I retired in 2014. At the time, I was the Deputy Network Director, Vision 16. Prior to that, for 14 years, was the CFO for the Vision 16. And then prior to that, progressive advancement through from a chief accountant to about final position. So a little bit of experience in this. Been exposed to a lot of development in the Vera model, the MCAS model, and those aspects, and hopefully can provide you with a little bit of perspective on how these things work and how the budget and the money flows. Been with Seth and the team for since 2014, and as like Seth said, visited very many hospitals and The more I visit, the more I find out about different areas of people's needs and desires. I will say, when you finish this today, you won't be able to probably be a CFO, but I hope you do have a little bit clearer picture of how the money gets to you at the facility level. That's all I got, Seth.
All right, thanks, Lynn. Very good. Like Lynn said, he's been very busy. We've had a lot of opportunity, and he's been a great team member and very widely respected for his knowledge and expertise. So something I certainly value, and why we wanted to have him on here with us today. And we do have some other team members on as well. So for the folks that are have joined us, we've got several people in the team that have served in the organization for a long time at senior level positions, both on the administrative and financial side, or together. And so we may ask them to chime in from time to time to share some of their expertise as well. Okay, this is a great chance for us to open with a really quick poll. The idea would be, this is what we want to know. For those of you guys in attendance, if you could rate yourself on a scale of 1 to 10, how do you rate your understanding of the entirety of the federal budget and VA allocation process? Okay, I'm going to cue this up here in a second. You're going to see you've got some choices ranged, if you will. And of course, 0 or 1 is like, hey, I don't know anything about this. This is all new to me. And a 10 would be, hey, I'm a big time expert on this and I know everything about it. So let's launch this poll. And anybody, just feel free to click. Totally anonymous. If you rate yourself as a 0, that's okay. No one's going to know who voted what. And we'll just take a minute here to give everybody a chance to respond to this. And this will help us understand where you guys are coming from and the range that we're dealing with. All right, got quite a few responses coming in here. And give it just another minute. Okay, the good news is we don't have too many in the 0% range. But it looks like, based on almost everybody so far voting, that we've got a really even spread between the 1 to 3, 4 to 6, and the 7 to 9, almost an exact. And it's interesting. I would say that actually probably mirrors what we observe on site. That spread among the knowledge level there. And Lynn, do you agree with that?
I do. It varies across the system, and some of it is just because it's not out in front of people all the time, and those the CFOs and those that get involved with it have a better grasp. That's good, though. It's a good range.
Yeah, so thanks everybody who has participated in that. Yeah, and again, I'll just note, when we're thinking of executives and managers and the fiscal staff at the facility level, having a pretty comprehensive knowledge of this process is important. But we also do believe that the other managers in the organization, to include the service chiefs, that it is helpful for them to understand something about this process, at least to get to a moderate level of understanding, because it is directly connected to what's going to happen in strategic planning for the future, and then certainly tactical and operational planning in the coming fiscal years. And so to understand, again, where your service fits in the facility and how that is linked back to the budget is something that we've seen really help improve an understanding of planning and accountability at the facility level. So with that said, I think we'll close the poll. Go ahead, Lynn. Did you want to add something to that?
Yeah, I just wanted to mention, you make a good point there, Seth, is that, if you're a CFO or if you're a visiting CFO or assistant CFO at a facility, some of this may seem rather elementary. But if you're an AO in medicine service or somewhere else in the organization, or even in some cases new executives that are in the organization, may not know all the details behind this. And so I think take it from where you sit in terms of what you hear today, and certainly we'll be open to questions as we go through. So.
All right, very good, Lynn. That is a perfect segue right into the meat of what we want to get into. And we'd like to start with the biggest picture. And so what you guys are seeing here is a high-level overview of the entire federal budget process. And Lynn, I know we don't want to spend too much time on this because this is really what's happening outside of VA. But if you could just walk us through it and maybe shed some light into what's going on here. My observation, looking at the chart, is wow, this is a really long process. I mean, we're looking at almost 2
Okay.
years between the beginning and when you actually get to VA.
Yeah, I will say, and again, you earlier said we're going to test out the interactive. I'm. Can you switch back to the slide deck for me, or there?
Yeah,
Okay, there we go.
there you go.
Good. Yeah. What yeah, this is a busy, long drawn out timeline, but what I want to point out here is that the budgeting process is not a 12-month or in some cases a 6-month process. At a minimum, it's 21 months prior to a fiscal year beginning that the upcoming fiscal year budget is being built. I'm not going to go through all of these points and stuff, but it's built upon what OMB and economic projections, and there's a lot of activity that goes on throughout the process. What I really would like to kind of point you to in terms of where does it start mattering to me in terms of the VA. Let me put it in instead of say we instead of me, but in the VA is that in the about 12 months out, agencies will start submitting their budget requests to OMB, and OMB will review that, and then and I tell this story because it used to be this way years ago. About November, they would send it back to the agency saying, we need you to take care of some of these things. We have questions. This doesn't look right. There's a term called the passback. The humorous part of that is it used to come back the week of Thanksgiving, and the response had to be back Monday following Thanksgiving. So it was kind of an interesting scenario, and those of us that were involved in that process spent most of Thanksgiving working on passbacks and stuff like that. But they've become a little bit more friendlier now, and things don't happen quite that way, and the turnarounds are a little bit more acceptable. So, but that's really that point in time when that passback occurs. That's when the wheels start turning, and there's starting to be discussion in VHA, CFO level, and the VISN levels about what the budget might look like in the coming year. And of course, if any CFOs are on here, you know how we are. We early in the year, early in the process, it's Chicken Little, the sky's falling, and then all of a sudden all the money shows up. But anyway, we go on through, and then the president sends his budget to the Congress about 7 months out. And that's really basically when you hear the State of the Union, that's sort of the timeline marker, the milestone is at the State of the Union is when the president releases his budget to Congress and then therefore to the public. And then the committee work starts then. That's where we start hearing on the news. It depending upon what's newsworthy that day, but about if Congress is going to pass a bill or not pass a bill for an appropriation. We start hearing those kinds of things happening and going on. So, and eventually, if things go well, we end up with a budget in October 1st. Now, the thing that I'll tell you, the other thing that you all probably know, or some may know, is that we have a 2-year budget in VA now, 2-year appropriation, which is the current year that we're going to in the subsequent year, which is a base budget. That way, if Congress doesn't pass an appropriation bill, we have a base bill to work off of, and therefore there's no continuing resolution that we're affected by. So that's another piece of the process that we go through. But those last 3 or 4 months is when everything it hits the news and the C-SPAN and all those things. That's where all the activity's going on between Congress. And ultimately, the Congress, the Senate, and the House will gather together and compromise on a bill, and that's what will come out. The other thing I want to say about it is, although this is a bill that's passed, it has to be appropriated, and there's an appropriation committee that has to do that, and they're the ones that are hold the strong purse string. If they have to appropriate the dollars to us, and that's kind of a subtle thing inside the process you don't ever see. And it's not anything that we pay attention to. Also, through in the process, the Congressional Budget Office, which is the comparable to OMB, which is the budget for the budget office for the president. CBO is the budget office for the Congress. They're doing their numbers too to make sure they're being processed and being assessed properly, at least in their opinion. So, and at that point, if it all goes according to the clock, to the schedule, we'll have a budget in October. Doesn't happen very often though, but we do have that base budget to work from. I think that's kind of all I want to say about. Yes, Seth.
Yeah, if I'm sitting at the medical center level, I mean, when would I start, paying attention to all this stuff?
Well, if it were me and I was looking at it from a perspective of a leadership role, I would be looking at it continuously, not necessarily these phases and steps that we're going through, but when I start looking at my budget, if a budget planning is occurring 21 months out for the national budget, I need to be paying attention to not just my budget, but what my direction is in the organization. We'll talk a little more about that as well, but what our strategies are, what's the secretary's direction, what's their priorities, how am I going to align with those things? I would start that early, and again, it's a continuous process. But if I was going to put a calendar on a budget planning year, I would start February timeframe with my strategic assessments and moving forward to a rollout of a budget by the end of the year.
All right, very good. Well, before we get into the next level of detail on the process, let's take a quick look at a budget snapshot for VA for FY19. And actually, let me add some data points, and then I'll explain what everybody's seeing on the screen. These data points that you are seeing here are from a VA Fast Facts FY19 budget one pager. I'm going to put in the chat a link to that. It's just taken directly from the VA public website for anybody who'd like to see this document. What it will let you know is that the total VA budget, this is the total agency-wide budget for FY19, is just about $200 billion. And that's up from about $186 billion in FY18. Now, about $110 billion of the 200 is identified as mandatory, and the remaining 89 is discretionary. Okay, and that's actually what you're seeing on this chart right here. And that total of what's almost 89 billion again. What we're really focusing on here, Lynn, is this top line, which is the 76.5 billion that's identified for medical care. That's the number that, as we move forward in this presentation, is the one that's being, divvied up, if you will, and allocated out across the system. Do I have that right?
Yes, you do. Very well done. I've taught you well.
Well, thank you, Lynn. Just wanted to share this because these are very current facts, and these are latest numbers, and it does give you, in fact, a scope for what we're talking about here. The agency's budget has increased, but there's also a lot of these areas, as folks can see, that do draw upon this large bucket of money to include things like 1.2 billion in this budget identified for electronic health record. Other things in here go to overall general agency operations, and you guys can see the breakdown there. But so here we're going to start to really drill down into how it works with the VHA's specific budget. So let's move on, Lynn. So here's us. Now we're really getting into the technical details of how this all works and how this 76.5 billion is going to get split up across, really 18 networks. I think it's 18. They, switched the numbers on us when they did the consolidations of some of the networks, the state. But I think we're looking at 18, and we've got everybody looking at, trying to find their piece of the pie. So, Lynn, we're going to lean on you heavily here to help us understand, okay? Let's move on to our next slide here, which is to get into this concept of Vera. All right, Lynn, take it away for us.
Okay, so first thing I want to say is, Vera, Veterans Equitable Resource Allocation Model, has actually been around for some time now, and it's actually proven to be a pretty sound system to allocate dollars. But I want to make real clear the term, it says allocate. I've always tried to stress to people that when I talk about the budget or working the budget is Vera doesn't produce money. It just cuts the pie and slices the pie. And how does it do that? It's based on workload that we categorize by in specific classes. And we won't go through the details of those classes, but there's 65 of them. And those patient classes are aggregated into price groups. And each price group is based upon, the level of care, the cost of care, and those types of things as to what the value, if you will, the reimbursement, if we were in a third-party arrangement, what the reimbursement would be for those patients. They use prorated patients, and I want to just take a minute or two just to explain prorated patients for those that may not know. It's a very simple concept to explain. Basically, if you have all patients, one social security number is a unique patient. That patient can go to 2, 3, 4 different hospitals throughout the year, and for each hospital, that's a unique patient, the same social security number. For the system, it's one unique patient. So for the purposes of Vera, we break those patients down and prorate their care, and it's based on simply how much is spent by that patient. And again, the devil's in the details about how the calculations occur in terms of cost for that patient. But just as an example, if I'm in Shreveport and I have to send a patient to Houston for a specialty procedure, and that patient's total cost is $100,000 for the year, and Houston spent $60,000, and Shreveport spent $40,000. The prorated patient would be 0.6 Houston, 0.4 Shreveport. So that's how the proration process works. If you can't add up prorated persons at a facility and it equal uniques. At the national level, you can do that. That would be the only place. PRPs, total PRPs nationally, will add up to total uniques nationally for VHA. But basically, the PRPs, they ensure that the funding is distributed properly, proportionately to the networks, because that's where I want to mention that. I don't think I mentioned that earlier. Vera is how the money gets to the VISN. We'll talk later about how the money gets from the VISN to the facility. And those shared patients, that allows it where we don't overstate the number of patients in the system. There's a point here on the slide too. It talks about high cost patients, which will come into play in a little bit as we work through the Vera model. But there is a safety net, is what I've always referred to it is. But it's kind of like if you're on personal insurance policy, your maximum payout is a certain amount. There is a high cost patient adjustment for patients that cost over, in this case for FY18, $119,000 for basic and complex care, and $293,000 for long stay patients. That you're basically protected for any cost above that. So there's a safety net for that, and that'll come into play as we talk through the next slides on the Vera model.
So Lynn, I'll go ahead and move us forward. So help us, maybe we do need to break down further this idea of basic versus complex, since it's such a significant aspect of this model.
Okay. So we'll do that in a future slide. It'll be more interesting to see how the numbers break down too. But there's two classes of patients that we have, two categories: basic care patients and then complex care patients. Just by their title will imply that the basic care patients require less intensity of care, less cost, and those types of things, as opposed to complex, which are high intensity, more expensive care cases, and more resources associated with it. And so those are the two classes. And if you look at the distribution of those in the next, in a little bit more detail in the next slide, if you go there, Seth, you can kind of get an idea of what's in basic care. Basic care is, your routine primary health care, some acute care, all the ancillary services associated with care, I'm not going to read all of these down through here, but one of the things that I want to point out is, there are patients in basic care that you would think would be in a complex, high-cost patient, but a lot of the cardiac patients, even open heart, falls into basic care. So there's a lot of, and there's some adjustments associated with that later on in the allocation to the facilities that we'll talk about. But there are some, although it says basic, there are some pretty intensive cases in basic care. Complex care, some of the things you would expect: spinal cord, stroke, heart transplants, blind rehab, those things. Again, I'm not going to read through all of those, but you can tell there's a lot of the chronic diseases and the long-term care type issues as well. But if you look at the bottom down there, this is the point that I want to make. There's 65 classes. A new class was added for 19 for transplants, but because they're going to handle transplants a little different than they have in the past. And I won't go into the details, but being centrally funded and that type of thing. But hopefully it will benefit the transplant sites quite a bit. But to my point, you can see that in basic care, and these numbers may be off a little bit from year to year, but about 94% of the patients reside in the basic care category and 6% in the complex. The interesting thing is the distribution of the dollars. It's more of a 70-30 split in terms of dollars between the classes. So you can see that there again, it points to the intensity of the care, the cost of the care associated with those patients. But again, what do you focus on in Vera? And we can talk about that maybe, but a little bit in terms of, how do you position yourself and those types of things. But it kind of gives you an idea of the distribution of those, the dollars and the patients.
So Lynn, I know this probably isn't a realistic question, but if I'm really truly looking at this by the numbers and only, through that lens, and I'm thinking about the future and how to maximize revenue at the facility level, and I realize we're still way back up at a very high level, but couldn't a takeaway be that man, I really should be investing in complex care because quote, that's where the money is, right? But that's not really realistic, is it? How would you respond to that?
No, I mean, I think that obviously, if you just look at the complex care side, most of those particular conditions or categories, they're pretty much, if somebody has a stroke, it's a stroke. Now, the key there is to make sure you've documented your records well, and the stroke is documented in the file so that they do move into a stroke category. But generally speaking, managing complex care patients is not as, to me, as critical as looking at your basic care patients between the 6 categories here. But just as you move through a routine health care basic patient class 2, I think is worth, and I'm not all right on the numbers, around worth $3,000 per patient. Whereas you move up to a multi-medical type patient, you start moving into the tens of thousands dollars of value. So, and there's so much that documentation plays into this, coding, being accurate. One of the areas I'll jump back over onto the complex side is home-based primary care. There's 10 visits a year is required to be classified into the home-based primary care. Otherwise, you may just be considered potentially routine care and basic care. One of the things I always stress was we need to make sure we're doing all our visits to HVPC. And one of the responses I always got was, well, that's gaming the system. And I said, no, it's not, because somebody has determined that is the level of care required for home-based primary care. And if we're not doing 10 visits, then we're not providing the quality of care, and was the perspective I took. So, I can get into a lot of detail, Seth, on that, but I think that's the kind of way you have to look at it. Make sure, the bottom line, the takeaway from this is, make sure your coding is good, make sure your documentation is there to ensure the maximum level of categorization patients you can get.
All right, no, that's a good answer, Lynn. It's one that does come up, at sites when they're trying to figure out, how to maximize that revenue, but to do it in the smart, proper way. So we really got one more step here when it comes to figuring out how the Vera is going to work. Can you help us kind of finish this up before we move to the next level?
Yeah, well, so we're going to talk, to the Vera PRPs are just basically multiplied by those category prices and class prices, and that produces for a network the level of funding that they'll get for general purpose dollars, or the general purpose dollars.
So that's at that moment.
That's pretty much. Yeah.
Yeah, go ahead. So Lynn, I was going to say, so at this point, so based on everything that we've covered so far, at the network level, a file is showing up that's saying, hey, here's your, keep it simple, here's your slice of the pie. So this is phase one of going from DC out to the networks. We got that right?
That's right.
All right. So let's move down to the next level. Whoops. Because this is where we're really going to get into what's, very relevant to a lot of the folks that are on with us today. This is hitting close to home, very relevant to their planning, and a lot of these conversations for FY19 at this level are happening right now. So we'll rely on you, Lynn, to help us keep breaking this down. And you helped us define that there's really 6 different components as we look at the level of the workload allocation piece of this. And so let's walk through this one by one, and you can help us, understand what each of these bubbles, if you will, are, starting here with PRPs.
Seth, if you don't mind, I just want to step back one quick second. I left something off of my discussion earlier that I want to mention, because the general purpose dollars are allocated based on the prorated persons times the class prices, but there are some other items that are allocated into the Vera model, which is equipment, which is done by PRPs, and it's just based on an amount of equipment set aside. But the high cost patient education and research funding support dollars are also included in the Vera model as pass-throughs directly based upon the facilities levels, and that'll come into play in the MCAS model, because those will be passed on to the medical center. So I apologize for missing that, but I think it's an important point to make.
All right, no problem. We want to get this right. So all right, so I've got us back down here and looking at this concept of facility level workload allocation, and I think we wanted to start with PRPs.
Yeah. So what we're working towards now is how does the money get to the medical center? And some of you may be familiar with the term MCAS, Medical Center Allocation System. But this is what we're moving into now. And so the core to the MCAS model is a patient weighted work, which is not a PRP. Okay, it starts as a PRP. But there's some work that goes on to try to adjust for the complexity, the level of care in those areas in age groups and the classes, to try to level the playing field to a certain degree in terms of the allocation. So it starts with these prorated persons, but those prorated persons are going to be converted into what's called FAC work, which is the next step into the process. And FAC work, the term is facility work, is a measure. I think if you go to the next one, Seth, is a measure that accounts for the resource intensity of patients within the Vera classifications. So what does that mean? It means that they're weighted. So this slide here kind of gives you this is the simple basic formula for computing FAC work, and it's the national cost. And you kind of watch my hands; they don't leave my arms at all. But this is the national cost per PRP at each class level. So let's just say acute mental health class level, divided by the national cost per PRP for all patient classes, for all patients. That gives what's called a weighted work unit, WWU. That's multiplied by the PRP to create the FAC work. Okay, so that does explain the formula. It's really actually very simple. it's the computation that can get complicated. But I'd like to show you here just real quick as an example of how it works in terms of a patient class. So looking at it in this data, I will tell you, may be a little bit dated, but the concepts are the same. If the acute mental disease class, it looks at the cost of care in eight age groups, and then gets a cost per PRP for the facility. I mean, for the nation, based on each age group. So then that number is the number, that's the numerator in that formula. So in the case of acute mental disease for less than 25 years old, in this example, the value is $5,710. That would be divided by the national cost per patient class, which is, I don't know what it is at this point in time, and this is old data too. So the numbers are much higher now in terms of the unit cost, but that's where the weighted work unit comes from. This is how it's looked at. This is done for every class, all 65 at 8 age groups. So you can see the complexity of the calculation behind the scenes that occurs to create this weighted work unit to create the FAC work. So back to the formula. Oh, I'm sorry.
Lynn, at the risk of, no, it's okay. I'm just at the risk of throwing you a curveball here. So where does all this data sit? Who owns this level of data? And where people look at this stuff?
Well, I guess it resides with the Allocation Resource Center. That's where all the databases are that are utilized to create the Vera model and all these PRPs, FAC work, and those computations. This is a good point. Maybe if I can, I'll probably mention this again later. But if you haven't gone to the Allocation Resource Center website within the VHA intranet, you really should. It's a very, very, very good tutorials in there on all of this, and for the most part, my education and what I've got here comes from that source. So I really encourage you to go there to spend some time looking at the data. And there's just all kinds of data points in there that you can look at.
All right. Well, I'm glad I asked. All right. Yeah. So we covered the formula. You ready to move forward to our next area here and talk about the idea of geographic adjustment?
Yeah. So from here on out, these are tweaks, if you will, to the model in terms of how the workload is adjusted before an allocation is done. So in Vera, and I didn't mention this either, but Vera there's a geographic adjustment for the cost of goods and services, including salaries and all, and that is not applied in this model at this point until we get into the MCAS calculation. So we are, hold on just a minute, guys. I lost my connection. Okay, now, so the geographic adjustment is applied to the FAC work, just like it would be in the Vera model. It's driven mainly by salary costs and locality pay. So what you would see is this would be a workload number. It's not a dollar number or a percentage or anything. It's a workload number. So in your high cost metropolitan areas with a high locality pays, you'd see a plus up to their FAC work to adjust for that cost. Because remember, we're building on a national cost, so it doesn't really reflect a specific area cost. So that's the first step. The next step is to take into account some resource-intensive cases of care. Now, the list is rather long, and it's based upon, it's looked at in two different ways. Inpatient, it's based on the DRG and the cost of the DRGs, and then the outpatient is the HCPCS codes and those types of codes, and the not HCPCS codes, but the coding of an outpatient. And those are cases where the cost of the care has exceeded the level within a class, and therefore there's a slight adjustment for that. where you'll see the bigger adjustments are those hospitals and medical centers that have the larger programs, and as such, the complexity level 3s may not see much of an adjustment there, but it's where there are some cases that are accounted for. Again, there is a database in the system and in the ARC web system. I believe on VSSC in the cube, there's a cube in there that gives that information as well. Okay. So, and then the final adjustment.
Yeah, go ahead. I was going to say, this is based on the facility level complexity.
Yeah, so this is a complexity adjustment for obviously there's 3 complexities, 1, 2, and 3, and then ones are broken down even further, but it's not broken down here. It's either a 1, 2, or 3. So this is an adjustment to kind of, again, one more time, to smooth out the variation in numbers to account for the complexity of work plus the funding streams for some facilities. So what you end up seeing here, if you ever looked at an allocation, MCAT allocation, you'll see that the complexity level 1 hospitals actually have a reduction in their workload, while the 2s and 3s will see a slight increase in their workload. That mainly has got to do with the funding streams of the research and education support dollars that come through for the complex hospitals that the smaller hospitals, medical centers don't have the ability. So it kind of takes into account that. So when this model was built, it was sort of like one of those aha moments of why is the complexity level getting less money, a less workload adjustment than a lower complexity? And we looked into that, and that's really the reason why. So it had to do with the funding streams from the pass-throughs for education and research.
Okay, so maybe a little cost intuitive, but makes sense in the end.
Exactly.
And so, Lynn, then all that comes together. All of that ends up. Sorry, I'll make sure we're in the right place to bring us to this patient-weighted work.
Right. And so it'll be different from that first bubble of prorated persons to us, but the patient-weighted work is the number or the data that is used to allocate money to a facility. So the next steps are allocating general purpose funds. Let me make sure I'm clear on that to the facility. So if you go to the next one, so we got the money at the VISN. Now we've run the patient-weighted workload. So now we're going to start pushing the money to the facilities. Before that happens, remember, Vera sent the money to the VISN. The VISN sending the money to the facility. So the first step in the process is going to be the VISN director is going to make some decisions about a reserve, which if anybody is wise in any organization has got some kind of catastrophic reserve built in. There are some limits. I think it's 1.5% is the limit that can be held in a reserve. And some VISNs, stick right with that, some less than that. It depends upon the funding availability as in the process. They're also got to pay for the salaries and operations and the leases and all that for the VISN office, so that part comes out. And then the other part is initiatives. I know some visions have consolidated units, lab, accounting, all kinds of different things. There may be a specific initiative for some type of telehealth program, or just things I'm thinking of that may be set aside that would probably most likely have been agreed upon by all the directors through their ELT, Executive Leadership Council. But these are all set aside. And also equipment funds are set aside. And I want to point out here, although Vera does an allocation of equipment, the VISN is not required to allocate that much money out for equipment. There's no requirement for that. So it may be, if you looked at Vera and saw what the VISN got for equipment, it may not equal what is allocated in the MCAS model. And set aside in the VISN for equipment. So then that kind of takes care of the stuff that needs to be paid for off the top. And then we do the general purpose allocation based on the patient weighted work that we previously calculated. And then the next step is to set into if you think of this as a spreadsheet, add the columns in for the education, for that's the funding that you get for support of the education program. That's based on the number of residents you have. Those high cost patient adjustments. Now this is not that resource intensive group. These are the high cost patients that exceed those limits that I talked about earlier in the presentation. And your research support is passed directly through to you. That's based on the research support dollars are derived from how much research funding your medical center has and the type of funding, whether it's VA sponsored, not VA sponsored, and those. So those are all passed directly through line by line for each facility. And then the next is the VISN adjustment. So this is where adjustments may occur or may not occur. It depends on the VISN, the situation, or whatever the case may be. There may be some decision made that one of our facilities is going to support an initiative, and everybody in the network is going to contribute X% to that, and there may be an adjustment for that. I know when I was in the VISN CFO and in the deputy network position, we tried to make sure it was a philosophy. Again, it was that facilities were not. If the MCAS would indicate a reduction in a budget below previous year, we would try to mitigate that at least to zero. So that would require us to move some money from other facilities to bring, if you will, that base funding back up. Over time, it will adjust itself because the gaps become smaller and smaller. We were fortunate enough to maybe have opportunity for some facilities that had double-digit increases. That was also a philosophy that you probably can't effectively execute that in a one-year period. So we kind of moved money around each year. It takes a number of years to try to make adjustments that way, but it does work. But those are the kind of things that can be done. There's various other reasons why, but I just gave you a couple of examples that I used when I was in the VA. So. And then finally, you go to then basically that's it. You add up all those columns across the page, and you end up with your medical center allocation for the MCAS, which provides you your funding to begin with. So, so now you've got it at the facility, and it's all up to you now to manage it at the medical center. So, and that's another whole different phase of the process.
Now, Lynn, I want to go back and ask one question. That was actually a question asked by one of the attendees, and I flew ahead a little bit too quickly. The question was asked back when we were talking about the big picture, but I think I can ask that question now, which is, so what is the time lag generally, if you can characterize it, between VA's getting its budget, and then, how long does it take for that to get through Vera? And, and then how long from there does it take for the facilities to get their MCAS, for the year? Because I know that timing can be variable, but could you ballpark that for us?
Well, yeah, I mean, again, it's all dependent upon when the final budget comes in. This year, I think it was June before the actual final budget came in. From a process standpoint, once that number's in, the Vera model is already run. All it needs is the number to distribute. So it's a rather quick process. And then the MCAS process, again, and typically VISNs have already know what they're going to set aside, what their initiatives are. There's really shouldn't be much. Probably my guess is notionally between the day you get your allocation budget signed, you could probably get it out with 30 to 45 days, if not sooner. It just depends on the process. So it's a pretty quick process because all of these things are already set into place. The numbers are there. The calculations, all it needs is the number to calculate on. So. All
right, very good. Well, Lynn, let's take before we wrap this up, just the idea that, all right, so this is, provides insight to how the money gets to the facility, but if you're at that medical center level and you're in that leadership team or in that management chair, and you're trying to think about what does the future hold for this facility in terms of its budget, what is the mindset? What can a facility really do to increase its revenues or plan to do that, or what is it realistic for them to be able to control? Are there kind of a few examples that you can share with us?
Yeah, I mean, obviously, there's two variables: cost and revenue. So the way to increase your revenue, what you really need to be doing is looking at on the general purpose allocation side. Let me put it that way. I'm separating that from third party collections for a minute. Is to really make sure that your coding and your documentation is well done and reviewed. I would highly recommend that you're having somebody pay attention to the classification criteria to make sure patients are being classified properly, that you're doing those kind of quote audits to make sure they're there, and to really to try to not, again, I use the term, I don't want you gaming the system, but making sure the patient is where they're supposed to be in terms of the hierarchy of the classification. It's very, very important, and it's very specific how they can be there. And if you're doing all you're doing, then that's what you should be doing for the patient and the patient care. Obviously, you need to be looking at your cost as well. I know there's so much, and my philosophy was we always only ever managed was about 2 or 3% of the budget. Most everything else is already set in stone with us, at least at a beginning point, with our staffing and our utility costs, our pharmacy costs, all of those things that are going into that. But you really need to be attuned to how you're spending resources that you have control of. I realize that a specific purpose funding there's not as much flexibility for you there, but you certainly have some room to look at that in terms of managing your cost and your revenues. Third party, you need to stay on top of that, and again, trying to make sure bills are out timely, and the collection process is working well, because the further you get away from a bill time wise, the less likely there will be a collection. So those things, although it's not a huge piece of the budget, it's pretty big. It's bigger than it used to be, I'll put it that way.
And then, Lynn, I guess, obviously, if there's a certain facility that is seeing sort of a consistent misalignment of their budget with their operations, I mean, it does raise some strategic level questions of, are they really positioned themselves to be in a financial balance? Are they providing the right balance of services? And I know, that's a multi-year consideration, especially when you factor in the idea that it takes a couple years for what you do and produce in terms of your workload to catch up to your budget.
Yeah, it is, and because it takes time. I mean, the workload for basic care patients in Vera is based upon data from FY 17 and 16 for FY 19, and for the complex is 5 years back. So it's not an immediate event that occurs. One of the other things that I wanted to mention as an example, because it came to me on specific purpose, and again, I think there's specific purpose is a good thing. It's funding some very important things, but sometimes we need to make sure we pay attention to what's being, what RFPs are being responded to, and asking yourself the question about the long-term impact of those resources, because those typically the funding ends usually 3 years out, and it doesn't always happen that Vera will fund that in the long run, because we're all competing for the same pot of money. And if everybody's doing the same, taking the same actions and steps, if you're not moving above the average, you're not going to make any difference in your Vera outcome. So, which is at the network level, but would make a difference in your MCAT outcome. So, yes, it's very complex. It's easy for me to sit here from a CFO perspective. Well, if you do this, we'll spend less. If you do that, the impact down into the organization, into the patient, is what is the most critical part.
All right, very good, Lynn. Well, let's do a quick summary, and then I'll leave one minute to wrap up and answer any remaining questions. We actually have another good question up here that I'll pose to you in 1 second. But just to quickly summarize everything you covered, and again, we could have gone on and on. We could do a very detailed version. Hopefully, we got folks the key points about what are those high-level macro factors that are happening outside of VA and the timeline that it takes for that to become relevant to the current upcoming planning year, if you will. The idea that we address some of those key decision points that are factored into the Vera model, and then moving down a level, what's happening at that vision level when it comes to using MCAS, and what are some of the adjustments in there. And then this idea that at the facility level, certainly being mindful of, how do we look at potentially increasing or fitting the proper revenue into the organization moving forward in terms of how it's going to operate and prioritize. But at the same time, managing costs is always going to be a factor that needs to go hand in hand with thinking about the revenue side. Is there anything you'd want to add, Lynn, from a summary perspective?
No, I think so. I think we've covered it all. I think, again, this is pretty high altitude assessment, but gives you a little bit better feel of the process and how the money flows. But I think you covered you summarized it well.
Okay. Let me put this question out to you before I touch on one final closing slide. The question here is, and I'm going to rephrase it just a little bit. Would you recommend any sort of best practice or recommended structure in terms of the staff that a facility would want to have on board to keep a close eye on the process from their view? In terms of budget or Vera coordinator, I mean, what would you suggest is the optimal level of support to help the facility manage this?
So yeah, I do have an idea there, and that's a great question because it kind of set something up. It's my philosophy. It truly is, and it's something we did in our network. But in terms of Vera and managing that, what I envision is a structure where you have a Vera coordinator in an organization that's really kind of the air traffic control type person, paying attention to all the numbers, looking at things and whatnot, but to train the organization to be able to analyze in their particular area their types of patients. And I'm not saying anything that people haven't already figured out to do and aren't doing, but to what I called them was clinical specialist type things, to persons that understand that classification for the patients that they see, and that they're monitoring that and they're working with their physicians, because having a coders and persons right there with that physician working with them, what I've seen happen is over time those physicians start looking for those people to help them to get to the place they need to be. So it is a structure, but it's a process whereby the organization begins to own the responsibility for Vera, not just a person.
That's a great point, Lynn. And I mean, I have to say, having worked with a wide range of sites, quite frankly, a lot of sites do struggle to have that expertise in-house and to build good processes around that. It does seem to be a weakness that we've observed, although certainly some sites have done an outstanding job with that. There's just not a lot of deep expertise in some of these areas.
I agree.
So I'm just going to make a quick comment. I promised everybody we wouldn't make this a sales pitch. What I will say is that every site is going to need to figure out a really good, comprehensive, integrated planning model when it gets to the operational year, focused on a specific fiscal year, when it gets to the operational level. Because, again, one year there may be facilities that come in with a very tight budget. And so the theme is really going to be efficiency and cost management, and looking, how do we make our resource pool fit within this budget, and how can we sort of, survive that challenge? Whereas other sites are going to be in a different situation where the budget is more flexible. They've got a good increase. And so their mindset going into that year and how they're going to operate and execute is going to be a little bit different. They're really going to be looking for setting priorities and getting, maximal alignment out of the resources. And if they're able to add, making sure they're going to the right place. And so, a lot of the work we do focuses on exactly that, which is using a planning model and tools that help get facilities to that outcome. So that's part of the reason why we wanted to share this entire concept with everybody who's on with us today. If anybody has any final questions, we'll hang on here for a minute. I do want you guys to know that I am available. You guys have my contact information through hopefully the webinar, and we can certainly get Lynn if you guys have specific questions. I'm not going to pretend to be able to answer your specific questions, but we'd very much like to thank everyone who participated. We will send out a copy of the slide deck and a copy of the presentation recording to everyone who was on. So thank you all. We'll hang on for another minute or two for any questions. Otherwise, thank you all so much, and we'll look forward to the next one, probably another month out. We'll tackle another topic and hope to have you all with us then. Thank you, Lynn, and thank you, Lynn, specifically for being on here with us today.
It is my pleasure, and glad to be speaking back with some of my friends from the VA.
All right, thanks everybody. Appreciate it. We'll see you guys next time.